Now you make it sound so easy, but what are some of the roadblocks that we might face while we try to do this?
Well, I think my job is to make it easy, because I can truly tell you for 25 years, it is not an easy road. Oftentimes it takes longer than you'd like. You know, I am a public health advocate and I stand in the gap between public health and faith. And sometimes, as you said, faith traditions are generational. You know, it's not that I just woke up one morning and I believe this. It comes from generations and generations of belief. So unfortunately, public health advocates don't really, because science is so quick, we really don't want to take the time to really shift a cultural belief. So that's probably the hardest thing, is waiting for the change, if you will. But in that we have to be steadfast. We have to be steadfast in giving information in a cultural competent way. You know, we may not talk to the faith community the way we would talk to a university. We have to provide, you know, factual information in a cultural way that faith communities can understand, and talk to their constituents, talk to their members in a way that their members will understand and change their health behaviors. It is not an overnight situation. It takes a long time. And also, we have to work to bring partnership. We have to help partner faith communities with science, faith communities with the university, faith communities with the medical doctors in their community.
Now, as you said, you've been working at this for 25 years. What kind of reception have you received while you're trying to bridge that gap? Has it been tough? Do you get met with like a stone wall?
Well, you know, no, absolutely, usually not. You know, I've done a lot of work right there in Soweto, starting back in early 90s, and now we still have relationships with some of the faith communities there in Soweto. Most times, as in Tanzania, where we now have an office, right here in the United States with African American communities, most times faith communities don't have the facts. So they are operating out of their religious beliefs and traditions. Once you give them the facts and begin to help them to understand the science, not just give it to them and leave, but build a relationship with them, help them to walk with them, help them in their challenge of making a shift, you will see they begin to talk a different conversation. But again, it's a long process. It's not just giving them information and say, oh, well, you didn't hear it, oh, they don't believe. You have to really take the time, build a relationship, continue to help educate them, and not think that they are just supposed to believe it because you said it. It takes time.
Now,
and the time is very important, because the value of faith communities is enormous. We must bring our faith communities into the fold of public health advocacy.
Now, what are some of the most common myths that you've encountered when it comes to these deadly diseases? Like, let's talk HIV and hepatitis C, because Ebola is quite a new one, but what are the most common myths you've encountered?
Well, the most common myth is that HIV is a wrath from God. You know, HIV, you know, homosexuality causes HIV. You know, if it wasn't for the homosexuals, we wouldn't have, you know, HIV. If it wasn't for the prostitutes, we wouldn't have HIV. If it wasn't for those unclean people, we wouldn't have HIV. I think that is a myth that permeates all over the globe, you know, especially inside faith communities, all faith communities and all ethnic backgrounds. And I think that we have to, over my time working with this of 25 years, we have to continue to educate. We have to continue to have conversation with people who are living with HIV, who are in faith communities. Because again, people who have HIV, people who have hepatitis C, people who have Ebola, they are members of faith communities. It is caused by a virus. It is not a wrath from God.